Call Health Committee meeting to order. Let's stand for the invocation. Father, thank you for today. Thank you for the gift of another day, the ability to be here. And roll call, Gail.
Mike Dobbins.
Here.
Dora Paskowski. Here. Sasha Blockbox Qualls. Here. Danny Callison. Here. Julia Coates. Here. Joe Deere. Kevin Easley. Here. Lisa Hall. Here. Johnny Kidwell. Here. Darrell Legg. Here. Cody Poindexter. Joshua Sam. Here. Mike Shambaugh. Melvina Sharppouch. E.O. Smith. Here. Candace Teehee. Victoria Vasquez. You have a quorum.
Thank you, Gail. I'd entertain a motion to approve the minutes. Second. Any opposed? Okay, on to reports. First one from the Claremore Service Unit, George Vallier.
Good afternoon. You should have my report there in your packet. First, we got our final letter back from Joint Commission, fully accredited. I think I brought up that they had come in back in December. So we're fully accredited for another 3 years. We've had a couple of primary care providers in the adult medicine clinic retire after a couple of long careers. But we have them temporarily replaced with some locum contract doctors until we can go get full-time docs hired through HR. In-house, we're working on an agreement with the fire department. If you may not know, but underneath part of our hospital, there's crawl space underneath that. Well, in order to get down in there, we have to have some policies and stuff on rescue and stuff like that. So we're working with the fire department to do inspections and drills on working underneath the hospital in the crawl space. So that's forthcoming. And then ER volume continues to go up. It's still hasn't got back to pre-COVID numbers yet, but it continues to increase. And we've had several requests from other federal sites. Our EVS supervisor has been going out and doing trainings and assessments of their EVS teams, help them get, we're very fortunate with Ms. Greenfeather. She's our supervisor over our EVS group, and they do a really great job. Joint Commission always compliments on how clean our facility is and what a great job they do. So she's been out helping some of our other facilities. Any questions?
Any questions for George? Okay, George, you're good.
Thank you.
Oh, hold on. I'm sorry.
You said, is the volume of COVID going up? Is that what?
No, the volume of the ER is going up. Before COVID hit, the ER was 150, 160 patients a day. And when COVID hit, it dropped to 50 or below. And now we're back up to about 125, 130 a day. So it's getting back up there. Mm-hmm.
Mike?
So what are the ramifications of getting it? Or it's not as bad as it was, correct? I mean, there's not as many hospitalizations and things like that, or is that incorrect? Or is people still getting hospitalized for it?
For COVID?
Yes.
No, sir.
It's
No,
really toned
this
down.
This isn't the number of COVID patients coming in. This is the overall number of patients coming in. I'm sorry.
But as far as COVID goes, what they're getting now is not the same as it was, correct?
I don't know that we've hospitalized anybody with a primary diagnosis of COVID.
Okay, all right, thank you. That's good.
You're welcome.
Okay, thank you, George.
Thank you.
Okay, up next, Dr. Steve Jones.
Good afternoon.
Oh,
You should have in your packet a report that we put out each month, and if there's any questions, we'll take those in a few minutes. I wanted to talk about a few things going on in our health system, and then I have a guest with me that I'd like to introduce you guys to. This week is Patient Safety Awareness Week, so there's going to be a lot of communication going out to all of our staff and the health field about patient safety and how we all work toward that same goal. So you may hear some of that this week from some of your constituents. There's a lot of communication going out this week. So we've just completed our second town hall meeting on autism. That work group has been working since the chief had put that task force in place back in April of '23. They are going to be putting a report together and submitting that. But that's been an exercise within our health system on seeing how what impact and how we can do a little better job being sensitive to those patients that come to us that have autistic needs and things of that nature. So there will be some changes that will roll out according to what that group has submitted in the future. Let's see here. We just rolled out a new service to our patients that is text messaging. You may have, if you've been to our health clinics, you may have got a appointment reminder on your phone if you have that, or if you're signed up for that service. You can also see that through your portal. So you're starting to see some of that stuff that we're bringing new technology and interacting with our patients in a different way, which is we've already seen an impact to that immediately. Within the first 30 days, we saw an impact on no-show rates. So we feel like it's going to just get better from here. There's going to be other things we're going to roll out in the future. We're looking at ways to work through the refill center and see if there's a way to integrate that into the portal. But that's on down the road coming. Also, we're looking at referral management through the portal. So with contract health services or purchase referred care so that people can actually track their referrals through their patient portal. Again, these are things that we're working on, putting together, how they integrate with our health record, and being able to access that through the portal. So there are a lot of things coming down the road that are going to make the patient communication piece a lot better. We recognize that that's a place we need to work on, so we are working very hard on it. Let's see, and with that, I'll take any questions. That's the last thing I had on my list to talk about.
questions for Dr. Jones?
Sure.
This past Saturday, my daughter was able to attend Operation Orange.
Oh, yeah.
And I know you're probably not directly over it or whatever, Natasha Bray, is that they done an outstanding job. I think we had 150 students, high school students, that were able to attend, and they went to 8 different stations and learned different techniques, and whether it be taking pulse or CPR or whatever. It was really, really a good program. And if y'all have kids or grandkids that are in high school, I'd really recommend sending them through it next year. And but I was really impressed with what's going on over there, Doc.
Yeah, it's a way to get kids encouraged and integrated into the possibilities of the future and what's out there. So it's a great point. It's a great program. Yeah.
Julia?
Hi, Dr. Jones. You and I had a discussion probably a year and a half ago, something like that, about dentures for at-large citizens and what was available, what wasn't, and the costs and so forth. Can you refresh me on that, and if there are any updates as to?
There's not any new policies or anything, but I can get you the policy, and we'll get that sent to you on eligibility for the denture program. It's a direct service, so you have to come to us for those services. But I can get you that and send it to you in email.
Okay. As I was recalling, there was a partial fee of some sort, like a...
Not for dentures.
No? Okay. All right. Thank you.
Danny?
Dr. Jones, with the new hospital and the new clinic at Salina, is that going to increase your numbers that you have, that you employ? Or we're going to have to hire quite a bit more people to staff these things once they get open?
Overall, yes. in the beginning, we're going to open them with what we have and anticipate how as the growth occurs, then we'll be coming back and adding those positions to the budget, yes. But overall, yes, it will.
And I think it bears mentioning too that in these new hires, we do have Cherokee preference
Absolutely.
throughout healthcare.
Yeah, that's
There
a
shouldn't be
law.
any departments within the Cherokee Nation that do not observe Cherokee preference in hiring.
Right. And HR is also involved in that, and they hold us to those standards. So there is definitely a procedure for Indian, Cherokee and then Indian preference.
Yeah, great. Sasha?
Thank you, Chair. Dr. Jones, sorry, I have a couple of questions
Sure.
here. I have your email. I've just gotten a few phone calls in the last couple of days regarding immunotherapy, and I know we've had this conversation before. What is the process of notifying our patients of discontinuing the administration of immunotherapy?
It depends on the specific, what you're talking about. So if you'll give me the details, then I can get back with you and let you know that exactly.
Okay.
Are you talking about just someone, it would be a specific situation for that case?
I have one from dermatology, but also a big one is the allergy injections or allergy serum.
So with allergy, are you talking about us administering them?
Right, I understand they're compounded at an outside facility. Have there been adverse
The problem with
events that
that
have
is
caused this change?
that you're having someone compound a drug. We don't have the chain of control of that drug. We don't know if that drug has hit its limits on temperature, high or low. We don't know what's happened with that, and then you're asking us to administer it without having a history of what could possibly happen with that patient. That was a decision that our medical staff took to MEC and further, and they decided that they weren't comfortable with taking that liability.
Right, and I understand that. What are we doing to educate these parents whenever they're told to come pick up this medication out of our pharmacy refrigerator? What are we doing to help them to ensure that the patients continue receiving their medication?
So that's the responsibility of each clinic, depending on which situation, and if they brought it to us, or if they had it mailed to us and picking it up, that's the responsibility of each clinic to contact that patient and have that communication.
Okay.
It's also
Any
a
other-
conversation they can have with their primary care provider as to what alternatives, what they can do, and what we can do for them.
I'm just thinking of some of the pediatric patients and parents that I receive phone calls from. Their concern is, whenever you go in to take your kids in for injections, a parent's having to hold the child and someone else is having to administer the medication. They're one person, they're worried about being able to safely administer these injections, but also worried about the storage. We're trained in healthcare to monitor the temperature range on the refrigerators. They're worried about the same thing in the home and want to do what's best for their child. And if we're providing that education tool for them, and what are we doing to help them to ensure that they're continuing to receive the medication?
And they still have the option of having that medication administered by the provider who prescribed it to them. We did not prescribe it in those cases. They have an outside provider that prescribed that medication. That provider and their staff can still administer that medication to that patient.
Second question, sorry. Has there been any change in pharmacy process in filling 90-day medication refills?
Yes, there is. We're currently moving to a 30-day refill. We are doing that in phases. Currently, the patients that have been affected by that have all been sent letters as to the reasoning why we're doing that. There's a lot of factors that go into that decision, some being patient safety, some being cost with those medications, some being that things change with reference to what diagnostic tests are needed to continue that medication. And if it changes and we gave you 90 days and you're 30 days in, then 60 days of that medication just got wasted. with the costs that are, all medications we're going through at different things that we're opening with service lines. Last time I was here, we had a conversation about oncology drugs, the cost that it is to our formulary. We have to look at every aspect of how we can expand that formulary and continue to offer the medications that we do.
Okay, I'm just looking at the Legislative Act 14-13, and it's an act relating to a 90-day prescription mandate. And on here, it states that in the event that Health Committee of the Council of the Cherokee Nation shall work with the Cherokee Nation Health Services. And this is the first time I'm hearing about it from constituents.
This is something that I think administration is looking into.
Okay.
Mike, are you through, Sasha?
Yes, that's
Okay.
it. Thank you, Chair.
Just a quick follow-up. I don't know anything about this, but, so these injections, are they like hypodermic needles? I mean, are they like an EpiPen type deal? I mean, is it easy? Man, I'd be scared for me to wield a hypodermic needle and, put it in my kid if it was a needle.
No, it has to be drawn up and injected, but typically, your allergist or the person that you're seeing for that prescription will take care of and do that. In the past, what's happened is they brought that medication or had that medication brought to our clinics and asked us to inject for them. Our medical staff doesn't feel comfortable injecting that
Right, I understand
medication
that.
if they've had no control over that medication.
Right.
And they don't know how that patient's going to react, how long they need to observe that patient, because they're not prescribing that medication.
So, but in the meantime, I wouldn't be, I don't know, like I said, is it a needle it is? See, I don't know. I would have a hard time doing that with the needle and, I guess, in the shoulder.
Yeah, and I don't know that it's, the intent is to have the parent inject the medication. It's the person who's prescribing or that office. I mean, when I was a child, I had to have allergy shots. I know what it's like, and we went back to that physician every week, and I got my allergy shot for a while. And then it went to once a month, and it went to once every 3 months. So, but they gave it to me. My parents didn't administer it to me.
Right. Well, that's good. I mean, that would be a problem, I think. I wouldn't be comfortable with it, but, it's almost, well, okay, that's all I need.
Speak from experience. My son had severe allergies, and he had shots every Monday and Friday. And so the nurse, like you said, it was the allergy doctor, they mixed the serum or whatever it is, and then they injected him, and we had to wait 20 minutes to make sure he didn't have a reaction, because if he had a reaction, then they would have to give him a shot or medicine to counteract that reaction. So, it is something important that we see that they have someone there to administer that medicine just in case of a reaction or something.
Exactly.
So, yeah.
Danny?
Doc, is this something with who I'm sure we contract out for allergists, we probably do not have one on staff. So are they in Tulsa? Is that where that we contract them out at, or is it here in Tahlequah, or where?
We contract out with several. We do have one here in Tahlequah, but we do contract out with several.
So these folks might have to be transferred somewhere closer if they're gonna have to go back and forth to take their allergy medicine once a week or whatever. Might be beneficial for
And
them
they
to
do
get
have
with
to
their
have
provider.
repeat visits with that person, because that person is the one prescribing the allergy medication, not us.
Okay, anybody else? Okay, Dr. Jones, we're ready for your
Oh,
guest.
you got somebody else.
Okay, Candace.
I just wanted to loop back to the 90-day prescription mandate act of 2013. So are you saying that it is now under further review?
No, I'm not saying that at all. I'm saying that the administration is going to be looking into that. So I don't know what that means, but that's what I've been told.
Oh, okay. So patients have already received letters stating that the
Yes.
90-day is changing?
Yes.
Okay.
Now, it's not, let me be clear about this. If the doctor decides that you need a 90-day dose, it is still available to you. It's not an automatic, you're going to get a 90-day dose. That is up to the provider to decide what you need as a patient, whether it be a 30-day dose, a 60-day dose, or a 90-day dose. or if you need 1 refill or 5 refills, but that allows the provider to make that decision. We're just asking that if it's medication that's under any type of diagnostic test, like for hypertensive medication, if they have decided to change it and you've gotten 90 days worth and you just refilled your prescription for 90 days and you're 15 days in and you're having issues and we change it, then we've wasted that medication. Because you can't bring it back. Once we prescribe it and you take it, we can't bring it back. The other part is compliance. What we're finding is when you have 30 days, you stay more compliant than someone who has 90 days worth of medication. So there's a lot of decisions that go into making, or a lot of things that go into making these decisions, and we're leaving the practice of medicine to our providers. And that's the intent of this.
Yeah, I understand the intent. I think that it does certainly appear that that intent is also codified within this particular piece of legislation. And the piece that we were missing is it seems the notification to council. So I just wanted to loop back on that. Thank you.
Absolutely.
Thank you for the time, Chair.
Okay, now we're ready for your guest, Dr. Jones.
All right. So Counselor had asked me to bring Dr. Harp up, and she is our new Executive Medical Director. She took the place of Dr. Montgomery back in October 1st. And so I'd like to bring her up and introduce you to you guys. And if you have any questions for her, I'm sure she'd be glad to answer them. So, Dr. Harp.
Welcome, Dr. Harp.
Thank you. Thanks for Jones for the brief introduction. He asked me to come here today just to kind of introduce myself and tell you a little bit about me. Several of you I think I've met either on a ball field or in the community. I live in Westville and different places. Some of you I think I've worked with before and on different things. So if you don't know me, my name is Dr. Beth Harp. I grew up in Adair County. I graduated from Westville High School. After I graduated high school, I went to NSU in Tahlequah, and when I graduated from NSU, I went on to OSU in Tulsa, the Health Science Center, where I obtained my degree in osteopathic medicine. When I finished that, I came back to the Tahlequah community. The OSU NHS at that time oversaw the family medicine residency program, and so I completed my residency in family medicine, and then after that signed up as a full-time physician for Cherokee Nation. I've been here working mostly in the Tahlequah campus. I was at Main Killer Clinic, the One Main Killer Clinic, for about a year or so, but I'm usually have been on the Tahlequah campus is where I've been. Just kind of a little bit about myself. I was born in Stillwell, technically Peavine. I think Lisa, I was actually born, if you know Dr. Martin, Dr. Dennis Martin was a family medicine doctor in Stillwell forever. His wife Mary was a nurse. I was born at his house. I was the third child, so I guess they were like, you know, whatever, health care is expensive. So I was there. I was born. My mom was from Westville. My dad was from Stillwell. Battle of Barren Fork, my mom won. We lived in Barren pretty much all of my life. I'm a member of the Cherokee Nation. My mom was a school teacher growing up. My dad worked for Cherokee Nation in various jobs. He retired ultimately from being a clinic administrator and has really good things to say about his time with Cherokee Nation, so much so my mom kicked him out of the house and was like, go back to work, you're going to drive me crazy. So now he's back working for the nation, just with some different things, mostly at the in facilities, actually. This is kind of odd, he's a business degree, but he loves it. Growing up, you know, I will tell you, I don't have my letter that I wrote whenever I applied to medical school. But it basically, you know, summed up, you know, I did grow up in rural Oklahoma. I was very close to my maternal, or my paternal grandma, who also actually was diagnosed with diabetes late in life, had lots of complications of diabetes, which ultimately she succumbed to. Growing up in that, you know, watching that happen, she had great access to care, you know, thankfully within the Cherokee Nation. Even then, when it was a very small, we didn't have like the original, you know, the second man killer clinic. We just had, you know, the little baby one, and she got great care. But it was something that I realized impact the community so deeply, and that's really kind of what led me into this career. I actually rotated in different things. I actually took my dental admission test, thought maybe I wanted to be a dentist, but changed my mind last minute, went to med school. It was great. But, I still, the reason I went into medicine is obviously to help people. There's lots of ways that you can do that. Preventative care is really deeply in my heart, and the reason that drives me to come to work every day. It's great to work with our public health team. I know Dr. Gann actually helped train me, so if I don't do a great job, we'll just blame it on Dr. Gann. No, I'm kidding. He was great. He took me under his wing while I was there in the clinic, and I appreciate their team. But like I said, I'm here. I'm available. If you don't have my information, just reach out, email. It's Beth-Harp. My first name's Emma, kind of confuse people, but I go by Beth. I'll answer to either one. So if you ever need anything, please reach out. A lot of exciting things going on in health, and we have a great medical staff, some great doctors, nurses, therapists, support staff, and we really are starting to see a change in the shift where we're seeing a lot of Native students, but also especially Cherokee students. We've got, I think 3 or 4, I think there's at least 4 residents that are graduating from a program that are going to be working for us come this summer, and that's so important, especially for, like you mentioned, your daughter. I went to Operation Orange when I was in college, and just being able to have those connections in Tahlequah and have a medical school there is so important for our future generations. So if you ever need anything, please reach out. If you have any questions, I'm happy to answer them. And thanks for letting me be here today.
Dr. Harp?
Yeah.
We're having this ceremony of, we're honoring 20 grads. I think they're both from Tulsa campus and the Tahlequah campus. Do you know roughly at this point how many of those 20 are going to be staying with us for now?
Not yet. This week they match. So they'll have their match week this week, and it'll take I can't remember how long it takes now, but it'll take a few weeks before we know who all we're going to keep. But right now they're all putting their name in a hat for the positions that they want, that they refer to as their match day. So we'll be finding that out pretty soon. There's a lot of interest. The medical school being in Tahlequah has drawn a lot of interest to our residency programs here and at NHS with the internal medicine program, which is great.
Yeah. Any others for Dr. Harp? Appreciate you coming, Dr. Harp.
Thanks for having me.
Okay, from Public Health, we have, who's first? Lisa, I guess, is first. Welcome, Lisa.
Welcome. Good afternoon. It's good to see all of you. That's a hard act to follow, I'll tell you that right now. I really do appreciate Health Services and Dr. Harp. And I'm going to tell you a fun fact. My mother was her first grade teacher, so I feel a little claim to fame there with her. So very lucky and very fortunate to have Dr. Harp as the medical director. You have our report in front of you today. I have a couple of things just to update you on, just to mention, and then I'm sure I may have some questions on some of the activities that are going on. I wanted to mention there is a breast cancer survivor luncheon on March 24th at the Chodas Center. If you know of any constituents or have heard of anyone, there is a sign-up on our Facebook page. We've been taking those sign-ups for a while, but just wanted to mention that. We kick off the 2024 Wings season on the 23rd in Bartlesville. And so that'll be our first race of the season. In conjunction with that, we have already started 6 different walking groups across the reservation, and we'll add 2 more in April. That'll be ongoing throughout the good weather time so that we can get people ready for walking, running, and hopefully joining in to our Wings program. Our public health educator staff is working on March 26th is Diabetes Alert Day. And they are working around observing awareness and having events around diabetes prevention, particularly around the risk assessment, so that you can get into potentially a diabetes prevention program. We are, as I mentioned the last couple of meetings, a very strong push around tobacco cessation. While we are having classes as we normally have, we have now a class that is a hybrid class that starts the 3rd Wednesday of every month, and so anyone across the reservation or off of the reservation as well, anybody at large or on the reservation can sign up to join those classes, and there's details on both our Facebook page and our website. And in conjunction with that, we are upping our work around worksite wellness when it comes to tobacco cessation, and have just started classes offering incentives to employees that want to join and sign up for smoking cessation. So to hopefully get more employees who are wanting to quit into the class. And as I said last month, we're really busy working on both the farmers market for this year and summer electronic benefit transfer program, as many of you have been seeing across the news. So if there's anything in the report or anything among those things that you'd like me to speak to, or if you have any questions, please let me know.
Dora?
Do you by chance have a date on the wings race that's going to be in Bartlesville?
I have it on the 23rd.
March 23rd?
Yes.
Thank you.
Sasha?
Lisa, I just had a quick question for you after the meeting on the school health profiles, if you don't mind.
Yes, absolutely.
Thank you.
Yeah. Anyone else?
Dr. Gann?
Yeah, Dr. Gann joined today, just in case you had some questions about the new COVID guidelines.
So we need to create some questions. Let's see.
If you don't have any, I'll just back right up. Yes, ma'am.
I'm sorry.
Oh, sorry.
Who's Candace and then Sasha?
I think we do have the same question, because you mentioned new guidelines, but I'm not aware of what those new guidelines are. And if you wouldn't mind giving us just a quick
Sure.
overview, perhaps, of things that may be germane to this particular discussion.
Sure. So CDC is taking the approach, and they had this mindset before, that the goal of controlling any respiratory disease is to keep our hospitals functioning. That's the priority. Everything else is important as well. So they've created guidelines that can be applied to any respiratory disease. So the big ones that we see seasonally are, of course, COVID, then influenza, and RSV. And the guidelines emphasize, of course, prevention, and preventing the spread as well as preventing people from getting sick. So it starts out with immunizations, right? We have immunizations for RSV, influenza, and COVID. And that's the single biggest thing that any one person can do to protect their community and to protect themselves. Then you add on all the other measures that we know about: ventilation in your home, ventilation in workplaces, masking if you're sick, and hand hygiene, like that, right? And then the next part of it is really, if you have respiratory symptoms, stay home, right? Don't go to grandma's birthday party if you're running a fever and feeling ill. Then the second part of that is getting tested. We have medications for influenza and for COVID that you can take that will keep you out of the hospital and help prevent you from dying, right? So COVID's kind of gone in the background, which is a nice thing. But I looked at the numbers for the last 3 months. So December, January, February. During those 3 months, 6,161 people died from the flu, right, total, over those 3 months. And for COVID, it was 24,844. So it's 4 times as many. So COVID is highly contagious, and it's killing people. Now the numbers are going down. So hopefully they'll stay down through the summer, and this will become seasonal with the flu. And it'll become just part of the background. Those numbers will continue to go down. In the last numbers I looked up this morning, about 70% of Oklahomans have some sort of antibodies to COVID, either from vaccination or being infected or both. Doesn't mean they're immune, that they won't catch COVID, but the risk of having major outbreaks is much, much lower than it was several years ago. Now, the other big change was that if someone is diagnosed or someone has a respiratory disease, they should stay home until they've been fever-free for 24 hours without taking any medication to put the fever down. And once that happens, they can go back to their normal activities. They also add that for the next 5 days after that, you should take those other precautions. So wearing a mask, washing hands, staying away from big groups, distancing at work if you can, and things like that. We won't see the words isolation or quarantine for a long time, I think. Those are off the board. So those are the recommendations. And CDC understands that They could put in the guidelines, you should stay home for 5 days if you have COVID, or 10 days, and people just won't do it. So their recommendations are based on science, but also an understanding of what the public will tolerate with these guidelines. Now, healthcare providers have a whole different, healthcare organizations have a different set of guidelines. So this applies to the general public and not to healthcare organizations. So those will be different. And I know Dr. Harp and Dr. Mara are working on those. Those haven't changed. Just a general guidance to the public on any respiratory disease, even the common cold. So stay home if you're sick, get tested because we got medication, and don't go back to your normal activities until 24 hours without a fever and your other symptoms are improving. People can have relapses, they get better, they go to work, they get a fever again, they need to go back home and start that process over. We have testing is readily available, health services, and we have the medications to treat COVID and influenza. So it's still out there, it's still killing people, it's still a threat, and we have to use our brains and take care of our communities.
I really appreciate that so much. Thank you, Dr. Gann. and
Sure.
Thank you for the time, Chair.
Sasha?
Dr. Gann covered it all. Thank you.
It gets a little complicated, and the vaccine recommendations now, there's 4 different tables on when and how many vaccines you should get. But you go knock on your doctor's door and talk to your doctor about it. So it's still really important.
Danny?
Dr. Gann, I read an article the other day that said the prescribing of Tamiflu is down this year. Is there a reason because of that, or was that just a false? You never know what to read anymore, whether it's true or not.
Yeah, I
So,
haven't heard that. Dr. Hart, have you heard? Yeah. So I think, think about reasons why, patients I've met that don't take the recommended medication. It's because they don't think they need it. It's really that. I'm at low risk. I have paid time off from work. And so I'm not going to take that medication because I don't trust it or for whatever reason. The Paxlovid that we use for COVID has some, people have a difficult time because it gives you a metallic taste in your mouth. And so they don't want to take it. Say, well, I'm not at high risk. And so from my public health perspective, right, if everyone who got COVID took Paxlovid, there would be less spread in our communities of COVID. I think as physicians, we try to pick out the people who are at high risk for hospitalization and for intubation and for death, and we have a really good hard talk with them about medications. There's also some really good evidence showing that Paxlovid for COVID, even if you're at low risk for being hospitalized, that it prevents long COVID, and we're still figuring that out. There's thousands of people researching that and tracking it to get a good definition of what that is, what are the risk factors, and what's protective to keep people from getting long COVID. But Paxlovid has been shown to decrease the risk of long COVID.
and also, if you catch the flu, are you more likely maybe to catch the COVID along with that? Because I've visited with several people that thought they had the flu, then 3 or 4 days later they lost their sense of taste and smell. So I just didn't know if the testing was different on this latest variation or if it was the same as it was before.
Same testing, and my textbook says that you're not going to get flu and COVID at the same time. Your body will pick one, or one of the two will overwhelm the other. And I think it would make sense that if I had COVID and I had some lung damage and I recover, and then I get exposed to the flu, I might be at increased risk for getting sick from the flu. Does that make sense to you, Dr. Hart? Yeah. I'm just an OBGYN doctor. She is the family medicine doctor. Bigger brain than I do.
Thank you.
Yes, sir.
Any others? Dr. Gann? I believe we're good. Thank you, Dr.
Thank
Gann.
you.
Okay. I see no old business, no new business. Announcements. I have one. I think all of you got an email and responded to the invitation for the medical school graduation coming up in May. It says 20 individuals, so some of those will be from the Tulsa campus and some from the Tahlequah campus. I believe that's May 14th at the Chota House. We certainly look forward to that. Okay, I need one more motion. Meeting's adjourned.